All right, let's get right into it. Think of this as a dry run for a consultant-level Viva exam in general surgery. I'll be playing the role of the examiner, and I want you to put yourself in the shoes of the candidate. Let's begin. Okay, so picture this. The moment's here. The exam is about to start. It's just you and the examiner on the screen. Take a breath. This is what you've been training for. And there it is, the opening gambit, a classic for a reason. The trick here is not to panic. Don't jump ahead. You need to be systematic, safe, and start with the absolute fundamentals. My response would be to lay out a very safe, structured approach. I'd start with a detailed history, really digging into the nature of that pain and the bleeding, then move on to the physical exam, but just starting with inspection. And this is the key safety point. If a digital rectal exam is just too painful for the patient, you don't force it. The next logical step is an examination under anesthesia. Trying to push through the pain isn't just cruel, it's useless. The sphincter will clamp down and you won't be able to assess anything properly. Okay, the examiner seems happy with that safe start. Now they're testing your clinical thinking. They want a clear, concise list of what's most likely going on. My top 3 differentials here would be an anal fissure, a thrombosed hemorrhoid, and an anorectal abscess. And the history is really what starts to separate them, right? A fissure gives you that classic, sharp, tearing pain right with defecation. A thrombosed hemorrhoid is more of a sudden, painful lump. And an abscess, well, that's a whole different beast. A deep, constant, throbbing pain, often with systemic signs like a fever. And just like that, the examiner narrows the field. They're steering you towards hemorrhoids. This is where they want to see if you know the step-by-step management ladder, starting with the simple, office-based stuff first. For office-based treatments, we're really talking about 2 main players: rubber band ligation, or RBL, and sclerotherapy. Now, RBL is often the go-to. It's got a better long-term success rate. But, and this is a big one, you can't use it on patients who are on anticoagulants. That's where sclerotherapy comes in. It's not quite as effective in the long run, but it's a safe option for that particular group. So, as with everything, it's not a one-size-fits-all answer. Ooh, a safety question. This is a big one. They're testing your knowledge of a major complication. Your answer here needs to be fast, confident, and absolutely correct. My answer is immediate, and there's no hesitation. Severe pain means one thing, and one thing only. That band is too low. It's been placed below the dentate line, where all the sensitive nerve endings are. That is a technical mistake, and you have to fix it right now. You go in, find that band, and you get it off immediately. Okay, so the non-operative stuff didn't work. We're heading to the OR. Now you have to walk the examiner through the procedure. They want to know you can do this safely and methodically. So I described the Ferguson, which is the closed hemorrhoidectomy. You start with a V-shaped cut on the outside, and then you carefully dissect the hemorrhoid tissue off the underlying sphincter muscles. You have to be super careful there. Once you get to the top, to the vascular pedicle, you clamp it, tie it off with a suture, and excise the hemorrhoid. The part that makes it a Ferguson is that you then close that wound up with a running suture. The idea is that this might help it heal a bit faster. A good examiner will always push you for alternatives. They want to see the breadth of your surgical knowledge. What else is in your toolkit? And why would you choose one over the other? This is a great chance to show you know the nuances. The Milligan-Morgan? That's the open technique. It's very similar, but the key difference is you leave the wounds open to heal on their own. Now, stapled hemorrhoidopexy is a totally different concept. Its biggest selling point? Way less pain, because there's no external cut. You're not actually excising the hemorrhoids. Instead, a stapler pulls them back up into position and cuts off their build supply. The trade-off, however, is a slightly higher chance that they might come back down the road. And pivot. The examiner throws a curveball, taking you right back to the start. But they give you a huge clue. That phrase, like passing broken glass, is a textbook description. They want the diagnosis, and more importantly, the critical warning sign. That history is a slam dunk for an anal fissure. And the biggest red flag you absolutely have to mention, location. If that fissure is anywhere but the posterior or anterior midline, major alarm bells should be ringing. That suggests something else is going on. So if I see an off-midline fissure, I'm telling the examiner that this patient needs a full workup. I'm now thinking about things like Crohn's disease, cancer, even TB or STDs. This isn't just a simple tear anymore. It's a potential sign of a serious underlying condition. This means we're going to need biopsies and probably a colonoscopy. Okay, correct answer. The examiner moves you on to the definitive surgical fix. This is absolute bread and butter stuff for a surgery exam. You need to know the name of the procedure and you need to know the numbers. The gold standard, without a doubt, is the lateral internal sphincterotomy, or LIS. It's a really elegant procedure where you make a small, controlled cut in the internal sphincter muscle. This breaks that cycle of spasm and pain, restores blood flow, and allows the fissure to heal. And the results are fantastic. We're talking healing rates of over 90%. Of course, there's no surgery without risk. And for LIS, there's one complication that everyone worries about. The examiner wants to know you're aware of it, and more importantly, what you do in the operating room to prevent it. The big one is incontinence, usually minor, but it's the main risk. So how do you minimize it? You tailor the operation. Instead of just dividing the entire muscle up to the dentate line by default, you only divide the sphincter fibers to the length of the apex of the fissure. It's about doing just enough to get the fissure to heal without compromising function. It's a real surgical balancing act. Another pivot. Now we're in acute sepsis territory. Throbbing pain, high fever, this screams abscess. But before you talk about scalpels, the examiner wants to check your fundamentals. They want to know you understand the relevant anatomy. Absolutely. So the story of almost every anorectal abscess starts with the anal glands. These little glands are tucked away in the space between the sphincter muscles, and they drain into the anal canal at the dentate line. If one of these ducts gets clogged, bacteria get trapped, and that's the start of an infection. That infection then spreads along the path of least resistance through the surrounding potential spaces. A perfect setup for the next question. You've explained the how, now you need to explain the where. This is about connecting anatomy to pathology.
Right, so that infection has to go somewhere. Most commonly, it tracks out to the perineal skin or into the big, fatty ischiorectal space. But it can also burrow into more complicated spots, like between the sphincters or even way up high above the levator muscles in the supralevator space. Knowing these different locations is absolutely critical, because where the abscess is determines how you're going to approach draining it surgically.
Okay, fundamentals are sound. Let's talk treatment. The first part is easy. The second part, about antibiotics, is a key question to show that you're a judicious and safe prescriber. The number one rule is simple: prompt and adequate surgical drainage. Antibiotics alone are not enough. Now, for a straightforward abscess in a healthy person, you drain it, and that's it. No post-op antibiotics are needed. But you do need them for specific high-risk patients. We're talking about people with a huge area of surrounding cellulitis, signs of systemic sepsis, anyone who's immunocompromised like a diabetic, or patients with prosthetic heart valves.
And here comes the end game. The examiner changes tempo. All right, candidate, a few quick questions to finish. This is to test your recall on the most critical can't-miss stuff.
Okay, this is a classic must-know scenario. Pain that is completely out of proportion to what you're seeing on exam should set off every single alarm bell in your head. There's only one answer here. This is a necrotizing soft tissue infection of the perineum, often called Fournier's gangrene. It's an absolute drop-everything, life-threatening surgical emergency. This patient needs aggressive fluid resuscitation, broad-spectrum antibiotics, and an immediate trip to the operating room for wide surgical debridement. Another great question about preventing long-term problems. How do you do a big operation without creating a new permanent problem for the patient down the line? The absolute crucial principle here is the preservation of anodermatum. To prevent stenosis, a surgeon must always leave adequate bridges of normal skin and mucosa between the hemorrhoidectomy excision sites. These bridges are vital because they prevent a circumferential scar from forming, which would inevitably contract and cause a debilitating stricture. And for the final question, this is really about your core surgical philosophy. What's the one thing you can never afford to forget? The principle is to always maintain a high index of suspicion for something deeper and more serious going on. When in doubt, an examination under anesthesia is your best friend. It's the ultimate tool to make a definitive diagnosis and avoid missing a deep abscess or a necrotizing infection, which could be absolutely fatal. That decision, knowing when to take a patient to the operating room to find the answer, is what defines a surgeon.